Hi, everybody. My name is Alyssa, and I am with NAMI Multnomah, welcoming you all tonight to our third Evening with the Experts presentation. We have Dr. Jason Chen with us today, who's going to be presenting, and I will hand over to him.
Hi, everyone. Yeah, it's so nice to meet all of you. Really excited to be here, and I'm really appreciative of being able to be part of this series. Before I share my screen, one thing I just want to let, as I start talking, just that I try to interweave a lot of resources that you can access on your own afterwards. I think that's often a question of what do I do with this information? So it's kind of split up in a few different sections, but there'll be some polls throughout to help us to get to know each other better. And kind of at the end of each section, I'll pause and try to answer any of the questions that come up. So just so folks, you feel free to throw your questions into the chat or just have them ready when I pause in between. We'll kind of go from there. I'm going to share my screen. Let's figure out how to do this. That's how you do it. Cool. Can everyone see my screen?
Yes.
Yep.
Yes.
Thank you. Yeah, and if you can't hear me at any point, let me know. I might not notice because I'm staring at it. But yeah, thanks again for having me. I'm Jason Chen. I'm a psychologist. You can just call me Jason. I'm just going to talk to you a bit about different suicide prevention resources you might access through a range of different needs. Just as we're getting started, just want to mention a content warning. As you know, I'll be talking about suicide. Of course, I'm going to be keeping it to safe messaging guidelines as much as I can. But just know that if at any point you need to take a break, please do whatever you need to take care of yourself. And here's just some other resources you can reach, in addition to just perhaps potentially things that might come up that cause folks to feel uncomfortable. Also, feel free to eat snacks, drink water, use the bathroom. I know these are hard calls to sit on for a long time, and just know, please do whatever you need to feel comfortable. Of course, unless there are things that you probably don't want to know about, then maybe don't do this on camera. All right. Just want to no conflicts of interest, and these are just my views. I'm just here as a private citizen today and not really talking about anything on behalf of the government. I just want to take a moment to acknowledge all the folks who've been affected by suicide, our veterans, service members, and their loved ones, and all the other folks who care for them. I feel like that's really the foundation of all the work I try to do. And know that we're all kind of part of this bigger journey in life together. Want to acknowledge some folks that have provided different resources or helped me kind of figure out different things to add to these slides, including our suicide prevention team, and also acknowledging all those folks out there that are really on the front lines caring for our veterans, service members, and their loved ones. Just kind of quick general guidelines, please, questions are welcome. I don't believe that there are dumb questions, so ask whatever you feel like, in terms of if you have a question that comes up. Keep in mind, this is a public forum, so even though things will be edited out, just, be judicious with your own information and the health information of others. And with that in mind, that I'm really not able to comment on any, if you're like, what happened to this person's care? I can't really comment on specifics for folks, as you can imagine. And similarly, just ask that people be respectful of each other's opinions. I know a lot of folks have different beliefs and places, ways they approach the content, and I respect that and hope we can be respectful of each other. Right, so just a little bit about me. So a lot of my research and work focuses on figuring out who's at risk, how do we help them, what gets in the way. And I try to do this in a few different ways. Looking at community prevention, how people think about treatment, some of the biology behind it, some part of my background. And also, what happens after suicide loss, how can we make quality of treatment better and incorporate more peer support. And also thinking about what are some of the challenges in our system and how we talk about suicide that can impact folks getting care. But I wanted to also get to know all of you better. So we have a few polls that Alyssa's going to put up. You don't have to read this tiny print. But the first one is just to learn more about who's in the audience.
All right, you should all have that poll now.
All right. Well, it seems like roughly, maybe there's one person missing. So, all right. So it seems like mostly veterans and also their loved ones. That's helpful. Just to, thanks for being here. Oh, there we go. So our second poll is just to learn more about what folks are hoping to get out of this talk today. All right, cool. Well, thanks everyone. I'll definitely be touching a bit about our current research and also a lot of things about resources and ways to help. I'm probably not going to talk a lot in a lot of detail about a lot of projects out there, but we'll try to at least give folks a sense of what's out there. Thanks so much. Really appreciate you taking the time to do these polls to get to know each other better. All right, well, I'm going to continue then. Do I have to minimize the poll, Alyssa, or does it just kind of disappear?
It should be gone now.
Oh, okay. Maybe it's just on my screen. All right, cool. So just thinking about big picture take homes today, for there's nothing else folks are kind of remember all this information. One is we each have a role. You know, there are things that we each play a part in supporting each other and also decreasing suicide across our community. Language is important in how we talk about suicide. And just to be sure you have prevention resources for various situations. I find I often tell folks, I don't have the answer, but I hopefully have a bunch of answers that one of which will work for you. And if not, we'll have other answers, hopefully. But oftentimes when I know at least in my life, when I am working with a friend who's in crisis, sometimes it's good to know where to find things, even if maybe you don't anticipate it yet. Just to kind of bring us back to some scoping. So based on I think they might have updated these recently, but based on current numbers, we know that about 500 service members died by suicide in 2019. Roughly 6,500 veterans died by suicide in 2018. So these are roughly the most recent numbers we have. And I don't know about you, sometimes it's really hard for me to know what these numbers even mean. So 500 service members is approximately 2 full movie theaters in a standard suburb of the United States of service members that died roughly in that year. Or roughly 2 cruise ships of veterans died in 2018, just to give a sense of what those numbers actually look like. And from here, I thought I'd start off just by going through some different kind of facts and sort of like a little activity we do here called myth or reality. So for each of these, we're going to put up a statement and you get to decide if it's myth or reality. So here is our first one. Asking about suicide may lead to someone taking his or her life. Myth or reality? Right. Well, it seems like that's everyone. So actually, this is a myth. So we know that talking about suicide doesn't generally lead someone to take their own life. If anything, a lot of research suggests when folks are able to talk about it, they feel better. Right. So moving on to our next one. There are talkers and there are doers. Myth or reality? All right. Folks are, majority of folks are once again correct. It's a myth. We know that in part, it's a little complicated, but we know that there are very few folks who attempt suicide who don't also talk about having suicidal thoughts. So saying that the folks who talk and don't act doesn't quite line up in some ways. But many folks do not. But whether or not they talk about suicidal thoughts doesn't actually give us a sense of who will or will not attempt suicide. All right, if somebody really wants to die by suicide, there's nothing you can do about it. Myth or reality? All right, seems like roughly most people have responded, and generally here we go. Yeah, this is also something we really consider to be a myth. There's in each of our roles, there's always something we could do to help, or we may have opportunities to help and support folks. On the flip side, I think one thing to often keep in mind is that at the same time, any one person on their own, probably they don't have everything they would need to help someone prevent someone's death by suicide. And we often think that it's no one person's fault usually. And with that in mind, there's no one person who can prevent it, but we all play a role. And for anyone who's ever heard Kevin Hines, who's a suicide attempt survivor, he talked about how if just one person stopped to ask how he was doing that day, he had said he would not have attempted suicide. So keeping in mind, sometimes these small things make a real big difference. All right, so this is our last one. So he, she, they really wouldn't die by suicide because of all these different reasons. They just made plans for vacation, have young children at home, made a promise. Myth or reality? All right. That seems like roughly most people. And yep, y'all all right. It's a myth. Oops. And not because that maybe having children or knowing they have loved ones doesn't make a difference, as much as these things are really complicated. There are a lot of things that happen when folks are really making that transition from having thoughts to acting on those thoughts that might not always fit the objective reality around them when they get into those modes. Oh, well, thanks so much for participating in this myth and versus reality activity together. In this next part, just to really expand more about, just to talk through, I wanted to talk with you through a little bit about what we know about suicide risk at this point from a theory standpoint. And then after that, I'm going to pause for a little bit of time to answer questions. Let's see. So folks have been thinking of theories of suicide for a really long time. So this is an example all the way back to Aesop, talking about a wasp and a snake who was in a lot of pain. So this is something that people have been thinking about for a while as to how or why folks die by suicide. And then a lot of different theories came along over time. So, Durkheim talked about a lot of the social theories of suicide, which I will not get into. And in part, I will also say, I don't explain it well. So I'm going to just own that. Then Steinman talked about this concept of psychic. So this feeling of physical pain just from emotional distress. And then Beck talked about hopelessness as a kind of a predictor of suicide. And Baumeister, I didn't list the specific year because Baumeister kind of jumped around, but really focusing on self-blame and how self-blame causes a lot of pain and then increases, the kind of zooming in on perhaps things that aren't great, and perhaps a lack of regulation around different behaviors. Each of these has been thrown out there, and for one reason or another, they didn't end up explaining as much as we would hope in terms of who may or may not be more likely to act on suicidal thoughts. So here's the kind of the most prevalent theory of suicide risk right now, which came about from Dr. Thomas Joyner, who's down in Florida State. And this is called the interpersonal psychological theory of suicide. And it's called that, and if anyone's heard of it, sorry, apologies for boring you, because it had really focused on these interpersonal factors. So on the left side, Dr. Joyner was trying to figure out, well, what is it that drives suicidal thoughts? And in his model, there are two main factors: perceived burdensomeness and thwarted belongingness, which are very, very long words that are hard to say repeatedly back to back if you ever have to do that. But the main concept is when folks feel like they're a burden on others and feel like they don't belong, that's in his model what drives suicidal thoughts, and that these are perceived. So that might not be the reality. They may have lots of loved ones, but they may feel like they don't belong with them. I'm sure many of us have heard in our lives like, oh yeah, I feel like I'm alone in a crowd. I know people care for me, but I just don't, I don't feel that emotionally. As you can imagine, there are a lot of folks who have at one point or another felt like they didn't belong or felt like they were burdened on others. And we know that with that internationally, approximately 20% of individuals on average have thought about suicide sometime in their lifetime. Now we know, really luckily, really glad this is not the case, that 20% of the world population does not attempt or die by suicide. So folks have been trying to figure out, and this was an issue of past days, like, well, we kind of have a sense of maybe what contributes to suicidal thoughts, but how do we know what differentiates folks who might attempt? And in his model, it's what he called acquired capacity or capability for suicide, where we, in his theory, we have this kind of evolutionary need to protect ourselves from harm, but that can be broken down over time through different things, such as physical trauma, emotional trauma, chronic illness, injuries. And then it's when that kind of breaks down over time with the combination of these drivers of desire for suicide, that's when, in his model, folks are thought to be at high risk for attempt or death by suicide. And if you're interested, Dr. Joyner's book called Why People Die by Suicide actually really walks through this model in a pretty intimate way in talking about his father's death by suicide. And he has some really fascinating videos breaking down how this looks in real life. So if you're interested in those things, feel free to read more. We'll warn you, some of the videos can be a little graphic. So what we found with Dr. Joyner's theory is, well, that's really useful at maybe big picture, but in the moment when someone is when someone is thinking about engaging in suicidal behavior, that didn't quite match. So knowing that folks might have this acquired capability that's sitting long-term and might just, when combined with these factors, there seemed to be some pieces missing. So that's where fluid vulnerability theory comes in. And it's called that because there's this concept that folks who are at elevated risk of engaging in suicide-related behaviors kind of have this existing vulnerability that can change over time they carry with. And then in this setup, the thought is that suicidal episodes are time limited, so that when folks are in that kind of moving into action phase, that they kind of last a certain time, but they also change a lot. So you might go up and down, or stay constant for a while and kind of gets a little funky. And that these modes are triggered, our vulnerability is triggered when something happens that puts us in the suicidal mode. So it can be a specific internal event or an external event, such as something embarrassing happens to you, or you have these thoughts that are really hard to manage. It could be something involving hopelessness, maybe a recent death, or one thing he also talks about, there's some emotions that kind of loop on each other. So for example, if someone's feeling really agitated and anxious about something, they might feel really bad that like, oh, why do I feel this way? I don't know. And it just kind of cycles. And then once it's activated, in this model, there's a thought that there are kind of two kind of competing pieces. One, there's a physiological piece where folks are feeling in this kind of fight or flight mode. Many folks describe being really anxious, on edge when they're kind of in a suicidal mode. And also there's sort of these competing motivations and urges on whether or not to act on it. And the thought is, if we can get people through this, on average, generally folks will return to that baseline risk level. So they'll carry that vulnerability, but they'll kind of return to their normal, whatever that might look like. So in thinking about just some of these current models, one thing that continues to be an issue is we have these kind of big picture things, but they don't always match with what we might need in the moment. And part of why we don't really predict suicide risk well. And it also seems like our clients, the research suggests, folks can't predict their own risk in a certain time, which I think speaks to some of the pieces that I'm about to talk about. One is that, and I want to clarify, so this is really focused on when folks report they made that shift. So this is different from maybe someone who has been planning suicide for a while. That we know can happen for a long time. But in the studies that are out there, a majority of individuals said when they finally went from that plan to, I think I'm going to attempt, they report on average 10 minutes or less. And that kind of somewhere in the median. So but that's like a kind of a small window, but if we look at more of the data, maybe around 30 minutes in that decision to attempt than to actual attempt. And as you can imagine, this kind of makes it a little hard for us to figure out how to reach folks in these moments when we don't always have a lot of time. So one framework that came out of this ongoing confusing puzzle of trying to figure this out is the ideation to action framework. And this only came out 5 years ago. With the real kind of going back to that earlier question of, so we know that not everyone who has thoughts of suicide acts on those thoughts. So what are some things that are really uniquely predicting those? So, and with the concept that a lot of our research predicting ideation might not be the same as things that predict attempt. So for example, depression is associated with suicidal thoughts, but not necessarily suicidal attempts. And folks might be like, well, that doesn't really make sense, Jason. And one thing to keep in mind when we talk about prediction, we're looking for the things that uniquely predict something. So if everyone who attempts suicide has depression, it's hard to know which of those folks might attempt. Same thing with suicidal thoughts. That's why in some ways suicidal thoughts aren't always a good predictor of suicide attempts, because almost everyone has suicidal thoughts before they attempt. So it's like, well, that's confusing. And in their research, this is what they came up with. Like, what are some things that were uniquely predicting attempt from ideation? So they looked at a few things like having a formal diagnosis of certain disorders, a history of sexual abuse, but still, they didn't find a lot that really differentiated folks. But this framework is now guiding us to really look at these things differently, because most of our research has looked at ideation. But that may not have helped us understand who attempts and who dies by suicide. So it's become a sort of a shift in how we try to think of things. And challenges of figuring this out kind of overall include like, well, what's unique versus common? Unique versus a common risk factor. There's so many things that put us at risk of various mental health outcomes. But so far in the literature, it's not really clear what predicts what. So it's hard to know exactly how you best address it. And with that in mind, a lot of the risk factors we previously studied aren't things we can always change. So that's like a thing that's like, if there's poverty in your community, really important, really hard on folks, increases stress, mental health risks. And from a healthcare side, we're not always able to change that. Or for example, on average, we know women attempt suicide more often than men, but men are more likely to die by suicide. And we have, changing someone's gender identity isn't something as healthcare providers would work. So that's another piece, like what are the things that we can actually modify? Since we've studied hundreds and hundreds of risk factors, that are a lot of things we can't always change. Or elevation came up. How high in altitude you live in is associated with suicide risk. I'm like, well, unless we move everyone out of the mountain states, I'm not sure if that's going to work out. The other thing we think about as a barrier is we're trying to predict really dynamic, quickly changing things with things we measure at one time point. So in an earlier slide, I talked about sometimes we have like a 10 to 30 minute window, but we're asking someone how helpless they felt a week ago. How will these exactly land together? Another issue that's been a challenge is that to do prediction or to really try to understand things, especially when we know that often there are probably a lot of different profiles of folks who attempt suicide. We don't really have enough folks in each group to really understand that right now. And I'm really glad that's the case, to be honest, that there are only so many folks who die by suicide. But it does mean that how we can piece those apart to figure out, like, well, how would we know if this person versus this person in these circumstances would attempt suicide is very challenging. And then finally, there are both clinician and client biases that I think are often the research suggests. So providers may have thoughts about how at risk someone is that may not always actually match the profile. There's some research on this. If you vary the, let's say you present a case with the same risk factors and you just change the age of the person, folks might think differently, or how much experience they have. But similarly, from the client side, folks sometimes may think some things are really, maybe certain things are more distressing, but that may not maybe predict their own risk in the moment. So these are just some of the barriers that we continue to face that so far we are still just working on. We talked a little bit about these in terms of just having limited research on knowing exactly how to figure these things out. And the last two challenges I would just mention are, there's a lot of stuff that, for example, we have some good research on, like screening for suicide in different settings and getting folks to care, generally helpful, but to haven't really gone out very far in our communities. So there's this challenge of how the system might need to be reworked to get that care to folks. And then finally, there's also just a challenge of resources, which I'm sure everyone here, it's not unique to suicide prevention, but it just is one of those things that is hard. A last model I'll talk about, which is just even bigger picture than what we talked about before, is what we call the socio-ecological model of suicide, or some people call it a public health model. And this is the one that's been adopted by the CDC and by many other groups to really better understand what's going on. So a lot of what we talked about was really things on this individual level and maybe a little bit on this interpersonal level. So someone's own risk and maybe some of their interactions. But we know it's much bigger than that. It's how we interact with folks in our communities, what's available in our communities even, and all the policies and structures and disparities out there. And this was part of what led to our Be There campaign, which was launched about, probably 10 years, 6-ish years ago, with the understanding that no one group can do it all, that we do need all of us to really make the big change, the gradual changes we need to have a big effect on suicide rates. And with that in mind, I didn't plan for that to happen. With that in mind, we have a saying that folks should never worry alone, that it does take kind of all of us. And I'm hoping that if you haven't connected with someone on the call today, that it's a good reminder that there are other folks out there. All right, well, at this moment, so that's a kind of an overview of the theory and background. I'm gonna pause now before I get to the next section, just to see if there are any questions. I haven't really kept good track. I don't even know where the chat window is, but it's somewhere out there. And I'll just pause here for a moment if there are any questions. I think the challenge with a lot of genetic studies is that we often identify genes that we don't really know what the genes do. So it's hard to know how you can act on them. There have also been a few studies with looking at genetics in brain tissue from folks who've died by suicide, but I don't know the specifics of that. Any other questions before I move to the next section? So I would say this is more the suicide prevention field as a whole, so not VA specific. I don't think there's been much new theory that's come out since 2016. And in terms of numbers for deaths, there's about a 2-year lag with the National Death Index data. So that's always a little behind. One challenge, and I think this is a problem in research, once someone does a project, oftentimes no one does a follow-up project. So for example, some of the research on how many minutes folks report between thoughts and attempt, probably someone should do that study again so we have more up-to-date info, I think. Any other questions before I move on? I don't know the percentages specifically, but we do know substance use disorders are a risk factor for suicide. You also bring up a good question in terms of figuring out if an overdose is intentional or not. And some of it depends on how each state does it. But we have some good research suggesting that there might be biases in how we judge that. So we had a project looking at that among women versus men veterans, where you would expect that who had had, so they had what we call self-directed violence, and then you classify, did they have suicidal thoughts or not? Mm-hmm. And it seems like women veterans are more likely to be put in the undetermined category for some reason. So, which we think there might be a bias there, but there's some research on that with overdose deaths too. So women are more likely than men, even if maybe they look pretty similar, to have their overdose not classified as suicide. Black, Indigenous people, color communities. So there's something, it seems like there's some maybe bias in the data. Right.
Thank you.
Sure. All right, cool. I'm going to continue then, and then we'll probably take just a little break for folks. So you're welcome to take a break. Cool, so just want to introduce just kind of like a case example person as we kind of think about it. So this is Joe, he's 48, and joined the Army after high school, served for 1 tour in Afghanistan, and separated after 14 years of service, and recently lost his job and has a pending divorce. I bring this person up just because our next section is like, well, thinking about we each have a vote, what are some of the resources to help folks participate in those roles in case you someday were to run into Joe or someone like Joe? And one resource we have is what we call Operation SAVE, which is an acronym that stands for Signs, Ask, Validate, and Encourage. It's part of a suite of trainings that we have, not just for adults, but also for youth, not necessarily the VA provides the youth ones, but what we call, I don't really like the term gatekeeper training, but well, that's kind of what they're called. And the concept is, well, if we help train folks up, they can ask and then help get folks to care. Because we know most folks who probably are struggling, they don't just they don't call the crisis line, they don't go to a hospital. They generally will show up with a loved one or someone they know. And in this training goes through signs of suicidal thinking. So here's just a bunch of different ones. These are just some ones that are what we call warning signs, especially if there's a change. So one thing we think about in suicide is warning signs where we think about things that have suddenly changed in someone's life that might increase their risk or change in how they're feeling. So thinking back to an earlier example of, let's say, depression predicting someone's suicide attempt, because if everyone's depressed, it's kind of hard to tell. But if, let's say, you were with Joe and like, wow, Joe's much more depressed than normal, that might be a thing to be like, wow, that might be what we think of as a warning sign. Sort of like the difference between one way we talk about is like a risk factor is like high blood pressure. So that's a risk factor for a heart attack. A warning sign is like you're having chest pain if you lost feeling in your left arm. That's when we need to get to someone. Here are just a few, but know that there are many ones. Anything they feel is out of the ordinary for the person. Sometimes they might even be feeling better suddenly for no apparent reason. You're like, wait, something seems really off. I should probably ask and check it out. And it just talks through some other things you might consider. So this really just to tell you a bit more about our training resources. With the real assumption that a lot of folks may feel uncomfortable asking about suicide or not know when to ask. And that's been a big focus of a lot of our campaigns out there nationally, not just VA, but including CDC, American Foundation for Suicide Prevention. Folks may have seen the Seize the Awkward campaign on how to try to get over that hump when we need to try to figure out what's going on with someone. And we really encourage asking very directly about it. And sometimes there are, so I just recently learned, and there are certain Native American tribes in the Southwest where talking about suicide is seen as like a spiritual curse almost, that it might make it happen. So for example, one theme folks have asked, well, how do you ask about them? And the guidance we've received is like, be really upfront before you ask and apologize profusely if you know that it might really offend someone's beliefs. And that might be in general a good thing that I think that we're still working on making sure we talk more about. We don't apologize for being concerned, but if there might be if our language doesn't fit what someone needs, is something to keep in mind. Here are just many other ways of thinking about how you ask about suicide. We found in research that you might, depending on how you ask, you have very different responses. So one thing to keep in mind. The V is for validate and trying to be there for the person. And one thing we always mention is really validate what is true. So if someone's like, oh yeah, I'll never ever find a job, telling them, oh, right, that's absolutely right. You'll never find a job, probably not helpful, but yeah, like you could validate the fact that, wow, you must be really stressed and feel really like hopeless right now, like that. And then the E, encouraging people to get help and trying to do it as much as possible. We know that for one reason or another, many folks with thoughts of suicide, there's one model about help seeking in mental health. It's called the cycle of avoidance model, where every time we get to the point where we think we need to seek help, we just push that threshold out. We kind of get used to it. And one way we can help each other is to try to help folks when they hit that point to be like, hey, I'm really concerned. I'm not sure this is just something that's just gonna, go away suddenly. And trying to get folks to help. Making sure it's something that fits for them. So especially keeping in mind our emergency services or 911, we often say that it's best as possible to make sure you make a decision collaboratively, with the person. Telling them what they need or don't need probably isn't helpful. But there is also, of course, doing what you need to do to keep someone safe, which is something that even when we provide information about our crisis lines, folks often say like, oh, if I call the crisis line, they'll send an ambulance. And that happens in a very small proportion of cases. A lot of folks probably wouldn't find any benefit from an ambulance coming if they don't need one. If anything, it's probably not a great experience. that's another thing I think can be helpful to be upfront about. But those are just wanted to tell you a bit about what resources are out there for folks to access. You know, NAMI has a bunch, but just know that there's PsychArmor, which is an online course that providers and veterans loved ones, there are a bunch of courses about military culture, asking about suicide and mental health. And part of each local suicide prevention team's activities is to do outreach. So you can always request a training from your local suicide prevention coordinator. I just wanted to show you, so if you go to this little resource, that you can actually search for who that is. Note these folks they're more, so they're not the crisis lines, that's what those in the clarified, but they more actually, and power to them, because it's a lot to do. They actually keep track and check in on every person every veteran who is at higher risk of suicide, who has been sort of flagged for that. And they check in with them every single week and make sure all of us are also doing our jobs. But part of that is they do a lot of outreach too, and you may have seen some of them at our different outreach events in the past. So just know this is a resource for any organization you may be part of. There are many different types of trainings out there, and I think it's important to find what's the best fit for you. So Operation Saves when we offer free of charge, but I know that some did for a while, folks doing mental health first aid. I think one gap for all of us to consider with these trainings is the research suggests that folks learn from the trainings, but they don't always refer folks. So it's something to keep in mind for all of us. Like, how do we, for our own selves, get past that cycle of avoidance where maybe we're not asking? And we'll say that it is hard to ask. I remember once I think I was in an Uber a few years ago, and the person who was the driver was sending a lot of concerning signals. And even that was really hard for me to do, even though I do it all the time at work. So just know it's really normal in a different context for it to be hard. Also, I wanted to make sure the car was stopped somewhere first, so that we could actually get help if needed. But this is something to keep in mind. All right, well, we're about at the hour, and I figured before I get into my next section, might be a nice time for a break and questions. But yeah, so wanted to see right now, before we take our break, any questions about training resources, things that you feel like would be helpful to ask veterans, service members, and loved ones when you're concerned? Yeah, and there are actually a bunch of other resources that, at least for finding care, that folks may also consider that if anyone's interested, I'm happy to kind of show you, for example, like, where can I find a VA with a residential substance use program or things like that? What treatments are even offered? Those are also, I think actually, I should find those real quick, and that way I can share those too. Okay, I'll just put it up real quick. I'm always like concerned about putting way too many links, but sometimes more links are better. Cool, so I'm just going to share a few other ones. And it's probably the best. This one might be. Because similarly, a question folks often say for that encourage or help things, how do I even find help? And I am going to completely be upfront. It is really confusing. Even from my end, I'm like, wait, who do I ask about this? How do I even find this person? So one option, so this is the National Center for PTSD website. We collect it's a collection of all information we have about PTSD, not just for veterans, but youth. It's kind of meant to be a resource for anyone. Note that there are a bunch of different other resources out there too. But for example, if you click the Find a Therapist button, that should probably, But yeah, if you click on this,
And we're still seeing
oh,
your slides. We're not seeing your web
oh,
browser.
thank you.
Yeah.
Oops, sorry about that. Can you see it now?
Yes.
Okay. That was way too many clicks. So, but here's our PTSD. I think if you type in PTSD program treatment locator, you can then find what types of programs there are out there. The main ones we have so our PTSD clinical teams are for folks who have experienced military trauma. Note that the trauma they work on doesn't have to be military related, but that's kind of their specialty. But let's say I wanted to find in all locations for residential programs in the country. You'd be able to find contacts for, and many of them actually allow self-referral, not all of them. And they all have kind of specializations, which this is the part that's helpful to work with the provider on. So for example, Bay Pines, which is in Florida, focuses specifically on MST. I think Cincinnati does TBI and PTSD. So, and there are also non-VA programs too. So for example, Wounded Warriors Foundation has one. So another resource just to highlight is, I think this is really in response to folks saying our websites look really out of date. So they went really far the other way and made a bunch of animated websites with little cartoons. So this is called Treatment Works for Veterans, and it goes through all the treatments we provide. I'm trying to move it for different things. And it talks about, so for example, let's say I wanted to click on depression. It takes you through a grid of different treatments that we have pretty good evidence for, and that we've also tried to test out with veterans and what they're like. And there's a bunch of different videos about. And each of these treatments as a national system, the VA is supposed to offer at every VA. And that's generally been the case. I'm at VA number 4. So generally been the case at each one. How available and when is a little trickier, but usually someone provides it. And there are little quizzes you can take too, just to kind of decide for what you might want. Part of what motivates them this is we tried really hard to match veterans with the right treatment. We did lots of years of research on that. Turns out we can't, but veterans know themselves. So the new guideline is to provide information to help them make a choice that fits their values. And know that sometimes they might change things. And I'll just show one more resource just in case you're curious about treatments we have. We also have our PTSD decision aid tool, which really walks through different PTSD treatments that are offered. And you take little quizzes, there are videos. What I tell folks is that if you like a lot of info, it's great. If you're like me and we're like, this is way too much info, I don't recommend it. But you could actually learn what some of these treatments are like. And once you pick one from our national PTSD website, you can also look at, so if you go to About Face, you can look at videos of veterans who've been through treatment and kind of decide for yourself. And you can actually, it used to be you could actually, you can still actually search by veteran, treatment, gender, service branch. I'm going to warn you, we have fewer than I would like in the Marine Corps. Clearly, more Marine Corps veterans, we have to get on videos if they're interested. But one thing to keep in mind is that folks try to be pretty balanced. These are real veterans, so it's not all sunshine and rainbows. And I appreciate that they made videos like that. All right, well, those are just a few more of resources, just in case you're trying to think about how to connect with folks. And we're at the hour, but I thought I'd pause just another few minutes in case anyone had any questions before we took a little break. So Barb asked about if a veteran has had a suicide plan in the past, is it likely they will return to a similar plan if they return to seriously considering taking their own life again? Yeah, that is a really great question. And I think right now the working belief is that folks get acquired capability with one method. So for example, they have to work themselves up to, for example, overdose. Um, but if they go to a different method, they would have to go through that process again. Um, so, so with that in mind, often we think that if you can get folks away from the most lethal method, they often don't change methods or they shift to a less lethal method. Now, the only trick is sometimes things happen where if the method is especially lethal and there's really not much time, where if they shift suddenly, we don't get another opportunity. But I would say it depends. But I think generally our thought is if someone, it doesn't happen so often, people shift methods a lot. But if someone is a person who shifts methods a lot, that kind of adds some other information. Oh, Jim had a question about the 988 number, and I just went to talk about that not that long ago. So that is supposed to come online in a little bit, but it's not active yet. And we don't really know when it is going live. Let me think. Let me look up if there's a good resource. I must say that the talk I went to made me feel a lot better, that they're really trying to make sure all the problems that could happen are fixed ahead of time. But with that in mind, the rollout is still, they're currently in the planning phase and trying to test out some things. But it is not live yet. So that was something that happened last year that I was trying to spread the word. It's not live yet. Please don't have anyone use the number because I'm not sure where it goes. All right. Yeah, any other questions before we take a quick break? All right, well, yeah, why don't we take like a 5-ish minute break? I'll be back in a few minutes and feel free to stretch your legs, drink water, or just hang out on the line. Whatever floats your boat. I'll be back in a few. All right, cool. Well, our next part, we're gonna be talking more about things that happen more on the community level. And especially how we talk about suicide. Yeah, and if there are, well, pause a little bit for questions. So this next section is about suicide safe messaging. And I'm going to tell you, well, just kind of walk you through some of it and what it is and how you might use it. So, and I first got interested in what we call suicide safe messaging. So my work started in adolescent suicide prevention. And we saw a lot of these different headlines out there, especially about bullying and bully side. And one of the things we talk about in unsafe messaging is when we really oversimplify what causes suicide risk. So in this case, bullying being equal to suicide. But the real concern is that when we send this message a lot to folks, it can start to change how suicide becomes part of someone's identity. And we saw this in some early work all the way back in 2009 with lesbian gay youth who said, well, you know, if I, no one knows, I can't come out, I guess this is my only option. We also know from TV shows such as 13 Reasons Why. So here's a graph of searches folks made about suicide. And we'll note that really thinking about how someone would act on suicide went up almost 30% after the show was released. Note that one thing that's interesting is that it was really only among the group that was portrayed in the show. So younger youth and older adults who are not teenagers didn't really quite show the same thing, which is really saying like how things are presented can really have large effects on our population. So, you know, now I work mostly with veterans, and I started to wonder and be concerned, seeing very similar headlines to what we had seen with our youth. And really oversimplifying this connection between veteran status and suicide. And similarly, really early on, we started to see maybe this is something those folks are starting to internalize. So for example, one veteran discussed, well, extreme would be killing themselves, or that's kind of the only option they might have if they were in a bad spot, or they might see it that way. We also know that our messaging can change how we look at folks. So in this study, veterans were asked about how folks perceive them. And one veteran said, I think they view us as more of a threat and more of a danger, in control, but can snap at any minute or do some harm. Another veteran talked about how they didn't feel like they could really express themselves or maybe act or on maybe some of how they're feeling. And that is why we have safe messaging. In part to really, we want to present information, but in a way that mitigates what we think of suicide contagion or clustering. So when suicide starts to spread in a group. And here's some, so here's some example guidelines. There are a lot of them out there, but just want to put some out there for folks to consider. One is not describing methods or details. So sometimes, so for example, very famous places folks hear about where people die by suicide, such as the Golden Gate Bridge, has led to becoming this sort of destination, which is probably not something folks wanted. And it took many, many years to try to increase the safety around that, even to having more barriers installed, which took probably 20 years, to be honest. And for folks who kept saying the barriers would make it hard to see the bay, I'm told the view is still quite nice. So probably worth for some extra safety. Avoiding normalizing suicide as a common event. So we want to normalize that folks have suicidal thoughts, that a lot of folks have thoughts, but we don't want to normalize that everyone is, like, oh, like you might die by suicide, everyone might die. That's probably not something that's very helpful for folks. Not perpetuating myths, which we talked about a bunch at the beginning. And also try not to use stigmatizing language or imagery around suicide. So not having a judgment value. So for example, oh, it was a successful suicide attempt. Well, does that mean it's unsuccessful if they live? That doesn't sound like a good meaning to convey. And finally, for any time we talk about suicide, to really also promote help seeking. So if you're going to talk about it, provide resources for folks and also let folks know it's coming. These are just a few guidelines. There are many, many, many out there. But just to give you a taste of thinking about in terms of how you talk about suicide, if you use social media, how you might post about it, even if thinking about how you share articles about suicide. Luckily, research suggests that more articles that are using safe messaging are more likely to be shared and more people look at them, which is good. Unfortunately, there are a lot of articles out there that aren't always great. And we know that it's very hard to, once they're out there, it's very hard to get them out of the circulation, Another thing I wanted to talk about with safe messaging is that safe messaging is really about when you're talking with other people about suicide in this more, in a place where you may not know how your message will impact folks broadly. So for example, if you present on it or posted about it or something, you might not know the different impacts it might have. But that doesn't mean folks say like, oh, safe messaging is censorship, Jason. People should be able to talk about their experiences. I'm like, I agree. People do have, folks have a right to share their stories. And it's important to think about your venue. That's something I worked on with a colleague who had a lived experience advocate who it was meant to be it was at a prevention walk, but their original speech was really focused on really graphic details of their attempt. There wasn't really any hope in it. And in talking with the person, we were like, well, thinking about our intentions behind it, there's a place for when we need to express our pain and grief. But that might not be at the prevention walk where you're trying to help people get help. Maybe that's in another setting, such as with a chaplain or therapist versus on social media, or having your own personal blog or journal. Once again, thinking about how and where you're sharing and what your intentions are, which at the end of the day is the core of safe messaging. What are you trying to get across, and how do you think folks will react? And I'm kind of have this running list of resources that I will work with Alyssa on sharing with you. So one thing I will get in a different spot is all the safe messaging resources. Oh, I dropped my pen. Okay, so that you can look at them on your own and think about how you might want to use them. So our last section is really looking more at survivors of loss resources. Once again, thinking big picture about how suicide impacts communities and how as a community we can help prevent suicide. Any quick questions about messaging before I move on to this last section? Oh, maybe it's in the chat. No, chat's not. Okay. Great. Our next part, once again, is a poll to help get to know folks. I think when we think about suicide prevention, it's not the what and how always, but also the who. And would love to hear from folks who are comfortable sharing if you've had any personal experience with knowing someone who's died by suicide or suicidal thoughts. All right, so it seems like a broad range of folks who've known folks who have died by suicide or had thoughts or attempted suicide. All right, our second poll is just to ask how you relate to the person, once again, if you're comfortable sharing. And thanks for folks who shared that. And there often seems like a range of folks, and many folks lost more than one person, or maybe in different things. Interestingly, in some of the research with veterans, seems like the most common person they know is a friend, and a lot of folks have lost folks to suicide even before joining military service. So, kind of an interesting thing. All right. Well, yeah, thanks for sharing that with me. Kind of thinking about what this means. So, I'm not sure I'm sharing this right, but so Julie Serrell, who's probably our person who did the most research on survivors of loss, said that about each suicide impacts about 135 individuals on average. It used to be a much smaller number, but Julie proved that was a lot more than that. So in thinking about kind of before the numbers we're looking at for service member and veteran deaths. So if we're looking at our Tampa Bay Buccaneers Stadium, I lived in Tampa, and so what a Super Bowl would normally look like. It's about roughly, oh, I've lost count, 14 stadiums each year of folks who are impacted by a veteran or service member's death by suicide. Oh, wrong button. And when we look at veteran populations, it seems like on average about roughly 47% of veterans report having lost someone to suicide in their lifetime. So folks often ask, well, as I mentioned, one thing at the beginning, talking about resources throughout the continuum, because sometimes even when we do our best, there may still be folks who die by suicide, attempt suicide, or have their own suicidal thoughts that then can kind of impact others. And just want to highlight a few resources that are out there for folks to consider. Wrong button. One is TAPS, so that's specific for military and veteran family members and loved ones, and also for veterans and service members. Um, so I did find out in talking with them that they'd actually originally didn't really have as much specific programming for veterans and service members, but they're expanding that, especially when they found that a lot of their volunteers were folks who had lost someone to suicide, but just hadn't told anyone. I know they do a wide range of different support options. I'm focusing on the more national ones, but there are also very local ones. There's also the American Foundation for Suicide Prevention Survivor Outreach Program, where they'll pair you with someone who's had a similar loss, who can reach out to you and talk with you and provide support. And then sometimes they work with TAPS, sometimes they have their own folks. So just know if you, often folks are like, well, who is this person I'm talking to? Why would they understand or have anything to offer? They're able to connect you to folks who are very more specific to similar situations. And when you go to their parent website, the I Blossom website, in the near occasion that happens, there's also a lot of really practical guidance on what to do directly after, when oftentimes we're maybe not in a space to really know what to do. There's all these questions coming at us, and it provides really practical steps of like how to handle, let's say, first responders, how to handle funeral arrangements, things like that. Another resource I wanted to mention is our United for Suicide Postvention through our Rocky Mountain MyRec, which is out in now Aurora, it used to be Denver, Colorado, and they provide a range of, I'm pretty sure it's more, a lot of different videos on clinicians, survivors of loss, but also family members and loved ones. They also have a really great, not that website in particular, but they have a guide for talking with youth about a suicide attempt in their family or death in English and in Spanish. So in the near occasion, that is helpful. And of course, there are also a range of grief and loss support groups nationally, but know that locally we have the Dougie Center that offers a lot of resources for folks when they're having grief, and they have a lot of resources for youth too, and also through young and middle adulthood that folks find helpful. I can't tell if the video is blocking the screen, so that's part of why I keep moving it around. Other things to consider in terms of what we can do, even knowing that we have lost someone, is really thinking about, it seems like there's some research about their relationship with the person's important, how recent it was, and how close you were to them, and also how people feel about the death, and how it changes someone's beliefs potentially. And that's something we're still understanding, even though we know that folks who, thanks for that message, folks who have lost someone may potentially have their own increases. We don't completely understand the how or why of that, but it seems like something about how close you are is more important than necessarily the number so far, more to be learned. But other things we can do and keep in mind are really being cautious about how we talk about messaging, and also how, if at all, we memorialize the person's death. And really keep in mind that it really depends. So generally, we discourage memorialization of suicide from an organizational standpoint, and really prefer that folks try to memorialize everyone, with the sense of concerns that sometimes they can romanticize suicide or treat it in a way that may impact others' risks. Other things we talk about are trying to really focus on how people lived too, not just how they died, and trying to see if you can channel those efforts into some area of growth for folks, either through advocacy or outreach. Things to keep in mind. Other things to consider is if there are specific remembrance dates. Oftentimes those can be sensitive periods for folks that maybe they don't even realize till it comes up. This probably isn't specific to suicide, but for example, I had someone I work with was like, I'm just having a really bad day. I was like, oh, it's the anniversary of my sobriety. I guess I'm really stressed today. I'm like, yeah, it's good to, I was like, oh yeah, maybe these are things to keep in mind, you know. Also knowing that a lot of folks have feelings of guilt or shame after the event, and know that they might even want to dive in to do something to maybe like, for example, some folks have really involved in suicide prevention or advocacy immediately after, and to encourage folks to take that time to grieve. Grief has its own cycle. Everyone grieves their own way. But what we do know is that if you don't grieve at all, it tends to come back at some point. So taking that moment to have that time before you dive into something that very understandably folks can feel really passionate about, but then maybe you don't always get the time for yourself to work through those feelings. Finally, anyone's existing mental health or suicide history, there is some ongoing research on whether the timing of when this loss happens makes a difference. So if someone already had prior suicidal thoughts, it seems like that might, folks may be more sensitive to loss than folks who don't. They did some studies looking at other types of trauma and timing. Still not clear, but just knowing that history. And also knowing that for those who experience loss, there is a lot of stigma. And if we can provide an avenue for folks to talk and feel supported, that's really helps to challenge that, because there, unfortunately, there are probably all these things that happen very quickly. Folks, other folks who maybe didn't know the person will ask why. They'll do unsafe messaging things like, oh, well, clearly this was the reason, or if they had done this or that, you know, and trying to help support folks through that is important, and that it's okay to talk about when you need support after loss. And I'll say it's something I think as a society is still growing on. Even as providers, we really, it doesn't, when I present to providers about suicide loss, they've often, it happens and folks don't talk about it. Even when we lose providers to suicide, folks do not talk about it. So, because there is probably a lot of that stigma. All right, so those are just a few things we can do. I find just having the stats and knowing that this happens isn't always helpful. So just know that there are a few options out there. Another thing that can come up sometimes, they can happen, is that sometimes there can be some conflicts in different groups you're involved in, with folks who are survivors of loss versus folks with their own lived experience of suicide. And Doreen Marshall is out at the American Foundation for Suicide Prevention, get a really great workshop on this, because I was like, how do I get folks to talk to each other? And one thing that Doreen recommends is really, naming the conflicts up front and that they could be there, and also helping people find their own different spaces with it. So having attended International Survivors of Suicide Loss event a few years ago, we didn't really talk about. So it was probably really for asking folks to identify and share their own experience. It was kind of hard to figure out how to resolve that when there were folks who had very recent suicide loss. So bringing it up front is important. making sure you talk about there's a lot of common ground, knowing many of our survivors of loss also have personal lived experience. It's not a us versus them kind of thing, which historically sometimes has happened in suicide prevention that we're working on, and kind of being aware of our own biases. And even now, there is challenges getting the groups to connect. So just recently, at one of our large suicide prevention conferences that have a lot of folks who join from lived experience and advocacy groups, there was a new group that came up because they didn't fit with the survivors of loss and they didn't fit with folks with lived experience. So now there's a separate group of impacted friends and family who are like, well, the other group really feels like we're part of them. So we need our own group. And I'm like, my hope is we can, of course, address unique needs, but also try to break these silos a bit more so that we're really trying to support each other as best as we can. All right, so just gonna sum up with some take homes. And just this first to say, as we've seen from our polls and also just from some of the statistics presented, that you are not alone in your experiences, that there are a lot of us out there. And I remember I was even surprised when you look at the national statistics of the percentage of folks who know someone who's died by suicide. It's up to around 60% of the population, which means most people do know someone who's died by suicide, and yet we don't talk about it. So a reminder that you are not alone in this journey and trying to be out there to support each other in our communities. And that we each have a role, and whether it's helping someone after loss, talking with someone who's currently at risk, trying to connect someone to care, these are all important. And but also knowing for yourself where that role ends, that we have our own space. So as I tell my friends, when I'm off the clock, who knows, maybe I provide advice that maybe isn't something I would provide my clients. So if someone has a breakup and we do Zoom video movie watching and eat ice cream and curse their name, I would not do that or recommend that to my clients, but I will do it for my friends. So knowing that each of us will have our own different roles and boundaries there. And finally, as a reminder, to have resources for a variety of situations, not only just the ones that we may expect, but the ones that could come up. And with that, just ending on a slide mentioning some of our great NAMI veterans-focused resources, including our veteran peer support group, NAMI Homefront, which I know at least one person on the call is involved in, and we have a peer specialist training as well. And with that, I will just open up for any other questions there might be with our remaining time. Definitely agree. I think one thing we often talk about is sometimes, this is a broader issue with field, but trying to also focus on things that we think are protective or strengths to build upon, and not just the things that make folks at risk. Stay tuned for a list of all the resources I clicked on rapidly, so you can have them on your own. Cool. Well, I hope you have a good evening, everyone. Thanks for being here, and thanks for all you do out there. There are a lot of gaps in the net that I think we all help fill in.
Thank you so much, Jason, and have a good night, everyone. And I will be following up with all of you tomorrow. Have a good night.
Have a good night.